Hi, I'm Andrew Whitfield Cook. At FX Medicine, we strive to be clinically relevant for you. So please get in touch with us if there's a topic you'd like us to explore or a specific expert you'd like us to interview. You can email info@fxmedicine.com.au or contact us via Facebook, Twitter and Instagram. This is FX Medicine. I'm Andrew Whitfield Cook. Joining me on the line today is Elizma Lambert, who's both a qualified naturopath and homeopath with close to 15 years' experience, who runs a busy practice and is involved in practitioner education. She always takes a generalist approach in the way she teaches and treats her clients, as she believes that there are too many specialists and not enough practitioners who see the big picture. Applying her knowledge on cellular biochemistry and genetics enables Elizma to navigate treatments for many different diseases and disorders. She's becoming well known for her ability to connect the dots between root cause, symptoms and genetics, and helping people to reach a better understanding of their health conditions. She travels regularly to Europe and the US to learn the latest techniques and connect with well-known and respected practitioners, but her clients are her true teachers. You can learn more about Elizma at mthfrandbeyond.com.au. Welcome to FX Medicine, Elizma. How are you?
Very good, thank you, Andrew.
Now, we're going to be talking about a very controversial subject and one which needs more attention in our community. That's the genetic predilection to addiction. So I guess we need to start off with what are we really talking about with regards to the genetic predilection? Okay,
well, if you look at the definition of addiction, it's it's a compulsive engagement in a behavior that is naturally rewarding, despite the adverse or the negative consequences that follows it. But there was a lot of research that was done by Dr. Kenneth Blum, who is doing a lot of research into neurogenetics and neurogenomics. And based on the research that he has done, the definition of addictions have somewhat changed, highlighting that addiction is more of a chronic brain disorder and not simply a behavioral problem of too much indulgence. So I guess what I'm trying to say is that addiction is not a psychological disorder, but more of a physiological disorder. And this is because there's a lot of neurobiochemistry that gets disrupted with addictions. And they are also now finding a lot of genetic components that can make a lot of people more prone to addictions or put them at higher risk of developing addictive behaviors later on in life. And one of the major genes involved here is the DRD2 A1 gene.
Is this the reward seeking?
Yeah, that's correct. That's
gotcha.
The gene involved in the reward deficiency syndrome, or RDS as it's sometimes called. So that one has probably received the most attention. There's a lot of other genes that are being explored as well. The dopamine transporter, DRD2 is another gene that plays a huge role here. And my understanding is that Dr. Blum is working on a panel of about 10 genes or 10 polymorphisms to sort of create like a risk factor score for people who may be at high risk for developing addiction, so that these people can be screened early on. And it may sort of like change the treatment of a lot of these people by looking at genetic variants.
But with regards to that gene, surely there's environmental factors that cement the behaviour. Is that right?
Absolutely.
Right.
The gene pretty much gives you about a 74.4% increased risk of developing addictions. But the environmental or epigenetic factors has a role of, I don't really know how to find these percentages, but according to the research, it can reduce the risk of that gene expressing by 30 to 50%. So your genes is not your destiny. There's absolutely a lot of environmental factors that can determine whether you are going to express those genes or not. I guess the problem in all of this is you don't necessarily have to be ever exposed to alcohol or drugs to develop an addiction, because an addiction can come from just from ordinary diet, just from the sugar in our diet, or you can become addicted to exercise. So there's a lot of other things that you can become addicted to that doesn't necessarily get recognized as a problem because it's not a drug or an alcohol. And, no one ever really sees it as a problem, and it may not necessarily be a problem, but you can still have those addictive traits when you have these genetic risk factors, but it may not necessarily translate to an alcohol or a drug addiction.
That's a really interesting comment you make, because a very wise practitioner who was a colleague many years ago, we were talking about, I think it was prisoners, criminals who had, found religion in prison. This wise practitioner said they're just swapping one addiction for another. And they become so fixated then on the religion as their outlet, if you like, of their addictive behaviour.
Yeah, that's absolutely true, yeah. Because it all follows the same, it's still a dysregulation in the dopaminergic reward system. So there's many, many substances and many behaviours that can feed into the system. And so if you take one away, then people are inclined to just substitute with another one. It's the same with smoking. How many smokers start to overeat? How many alcoholics start to overeat when they start giving up alcohol? So you are just really swapping one for another. And it's interesting that she was mentioning about the prison system, because if you look at the DRD2 or the dopamine transporter, if that one comes into play with a DRD2 and it really amplifies addictive behavior, that one specifically is very much associated with violent behavior as well. So it would be interesting if you ever could do the genetics of a lot of prisoners, who are in there for violent alcoholic outbursts or crimes that involve drugs. It would be really interesting to see what their genetics, look like. Because if you just have the DRD2 gene, you may not necessarily have those violent tendencies. It's just an addiction.
Yeah.
But I thought it was quite interesting.
And this is the thing that gets me about how medicine is sort of, I get the caution of medicine with regards to genetics, but I don't get the dismissal by some quarters of the medical profession of genetics, of SNPs and things like that, because boy, I just see in times to come that this is going to give a roadmap of risk. And we're quite happy to look at risk factors for Alzheimer's. We're quite happy to look at risk factors for cardiovascular disease. Why are we not? Why are we dismissing still? Or there's real reticence to accept that our genes are with us. They're here. They're not like something that you might run into. You have them, and I get that they're not a given that you're going to get a disease in the future, but boy, it gives you a roadmap of risk.
Oh, absolutely. If you just look at the risk factor of the DRD2, I mean, that's a case in point. There was just such a huge correlation. And, one of the most interesting things is that they actually found that in families where this reward deficiency syndrome is really strongly expressed, they found that the man and a woman in a married relationship, they both had the genes. So there seems to be this attraction between people with addictions, which I thought was fascinating. It's literally like the DRD2 genes call to each other. So they found this really high correlation with men and women with DRD2 genes getting married. And this is not just in families with really, really strong expression. I'm not suggesting that everyone with addictions do that, but there is a strong predilection. And if we ignore genetics, this is, in my opinion, one of the reasons why so many of the drug treatments fail, because the relapse rate is just enormous. And I think this is because we are ignoring dopamine receptor expression and a lot of the genes involved in that. And if we can screen people, and I think we need to also be very careful with that, because there's a lot of fear of being boxed into an area or having their insurance denied because they've got some kind of genetic predisposition. So I think there's still a lot of things that needs to be sorted out there. But if we could use it for good and we could use it to screen people and in so change our lifestyles and our behaviors and be aware of where we need to be careful of, then it could just prevent so much problems down the line, you know?
Something that you said earlier, I'm just checking myself on, and that's with regards to an addiction to exercise or an addiction to religion. You said something about that you keep doing it despite having negative consequences. So therefore, we know that excessive intake of sugar leads to metabolic disease, diabetes, cardiovascular disease, stroke. We know that smoking tobacco, drinking alcohol, taking illicit drugs, certain illicit drugs, have adverse effects on not just self but family, community. We get that. But what about exercise?
Well, you know, as someone who used to be addicted to exercise myself, I can say that everything is good in moderation, but even something as good as exercise can have negative consequences, because what can happen is your body doesn't get the recovery time that it needs. So you can ignore all of those signals that your body is telling you that you need to take it slow, that you need to maybe change your exercise, have more recovery days. You ignore those things and you push through and you sort of develop injuries, chronic muscle breakdown, chronic tissue breakdown, end up with injuries. Then you can't exercise, so then you plunge into a huge depression because now you're not getting your dopamine high, and that can put you at risk of then grabbing onto other things to get that dopamine high. So this is sort of like the spiral that a lot of elite athletes. I mean, we've seen it with Grant Hackett. A lot of these elite athletes can run into this problem when they can't exercise anymore because their bodies have just broken down. They will grab onto something else to get that same kind of feeling. So yeah, even exercise in excess can have negative consequences.
You spoke about a personal journey with an exercise addiction. How would a practitioner, if you went to see them, tease an addiction to exercise apart from an eating disorder?
Yes, well, for me, if I would usually have a huge questionnaire, and based on the questionnaire, I can figure out what's going on in their biochemistry to a large degree. I guess this is where you have to ask them other questions. You have to, when exercise becomes disruptive to the social interaction with other people, when it becomes an obsession, when, I can remember at times when, it was Christmas Day, the gyms would be closed on Christmas Day, and I would be like, well, what do you mean the gym is closed on Christmas Day, So it's that really absurd kind of addiction. Everything just revolves around that.
It's like an OCD thing, isn't it?
Yeah, it's an OCD. Yeah, everything revolves around that. If they can't exercise that day, they are miserable. And so that's when things become really pathological. But this is where careful questioning from the practitioner side, needs to be engaged in. You can often also just look at the person and see, is their body being, breaking down in like a catabolic state? Are they obviously taking things too far? Is that all they can talk about? So I guess when everything becomes fixated around something, then that is an addiction.
Yeah.
But that will require, careful observation and careful questioning of the practitioner and reading between the lines. See if they may have had past addictions. Maybe they used to be obese and now they are gym junkies. So they've substituted carbs and sugar for exercise. It's looking for patterns in their lifestyle.
When do you see this sort of patient in your practice? Do you see them at the beginning or when everything else has failed?
Well, I see them generally when everything else has failed, because a lot of people would have tried hypnotherapy. A lot of them would have just tried, going cold turkey, whether it's to do with food addictions or nicotine addictions or alcohol addictions or drug addictions. And so it's usually when they've realized their willpower is just not winning out on this battle for them, and when all other therapies have failed, that's when we start looking at biochemical reasons, because I feel that is often being missed, because we see addictions largely still as a psychological disorder. So we'll put people in therapy or put them on programs. We are often still missing the biochemical aspects here, which has got more to do with neurotransmitter dysregulation, and receptor resistance. So that's usually, I would see them at those later stages when everything else has failed.
You know, I'm still wondering in my mind about, it was a slideshow that I saw, and I'll put this up on the FX Medicine website for our listeners, and that's it was by John Saunders at Sydney Uni, Southwest or South Pacific Private, and it was titled Understanding Addictions, Perspectives from DSM-5 and ICD-11. It was a presentation that he gave, and gee, there was some good information on there. One of the interesting things that I remember reading was about how the reward system became underactive because it's been hijacked by the addictive process. Then the excitatory system is hyperactivated in response to whatever substance you're addicted to. Can you measure this? And if so, how do you measure or to decide that it is actually an addictive process going on?
That's a really, really good point. I would love to see the slides that you're talking about, Andrew. That sounds really interesting. He's certainly correct. Like, what happens is you have this underactive dopaminergic system, and so you're trying to drive up the dopamine to get the high. But the problem is when this happens in a chronic situation, especially if the dopamine receptors are down-regulated. It's the same as insulin resistance. You have to produce more and more and more dopamine to get the high.
Yeah.
Now, because you're producing so much dopamine, you are now shifting the bar, so to speak, because we all will have a level. Let's say if we take the normal level of dopamine, once we get there, we feel great. Everything is fantastic. Now, if you keep on having to produce more dopamine because the receptors are not sensitive enough, then you're going to raise that bar. So now a normal level of dopamine is not enough for you anymore. You always have to go for that higher level. And so that's why even at normal dopamine levels, the body will still be in a low dopaminergic state for that person because the messages are just not getting through. Now, how you measure that, that's a very interesting idea. And I guess at this point in time, the best way that we can measure it is by doing something like, let's say, a urinary neurotransmitter test,
right?
Which is the best thing that we've got to measure neurotransmitters because we can't measure CSF neurotransmitters. So you can do like a urinary neurotransmitter test. And then you could possibly do something like an organic acid test, for instance, which is another urine test. And that way you can measure the actual dopamine in the system, and then you can measure the dopamine breakdown products in the system. And I guess from that, you can sort of start putting some of the puzzle pieces together and like how much dopamine is being produced, how much dopamine is being broken down. Because if you have to produce a ton of dopamine to get a message through, and the body's not really using that dopamine, so it has to do something with it. It'll have to put it through the COMT enzyme to break it down and through MAO to break it down. So you can look at those byproducts and you can look at the dopamine production, and possibly that can give you a lot of clues of what may be going on in this person's system. The trick in here lies is that it will change depending on the stage they are in. You know, in the beginning, the dopamine levels may be actually quite high, whereas sort of towards the chronic stages of addiction, you know, after years and years and years, it may be really low because it's like it's depleted.
Yeah.
You know, there's not that much left anymore. So you have to take everything into context. It's not a set standard, markers or levels that you could look at. You have to put into context with how long has this been going on, there may be other genetic variabilities apart from the DRD2 like COMT and MAO gene mutations as well. But those can sort of start to form a picture in your mind about what could be going on with this person. But then you can also check, there's also a role with dopamine and insulin and dopamine and thyroid hormones. So I think it's getting a really complete picture that's going to give you the better answers at the end of the day. So a lot of investigative work.
With regarding dopamine, and you spoke about the acute versus the chronic phase, in my head, I'm just wondering if there might be some link or hint with regards to, let's say, particularly females in the beginning stage, that they tend to not suffer from cyclical mastalgia with regards to their periods, because they've got a lot of dopamine, which is as we know, prolactin inhibiting hormone, that's the other name for dopamine, versus the chronic stage where they end up with worse breast pain because their dopamine's depleted. So therefore they've got nothing to antagonise that prolactin. Do you ever see that?
Yeah, absolutely. That can absolutely happen. I think low dopamine is a bigger issue in women than what we recognize. I mean, dopamine will, first of all, it will naturally tend to drop off after menopause as estrogen levels drop off anyway. So that seems to be a thing that happens, and why a lot of women, when they go into menopause, become more depressed, etc. But when they are not going through menopause, when they still have active hormone production, and that dopamine gets depleted because of just stressors really pushing that system, then yeah, absolutely, you can start seeing that change happen. And I have seen that where women's PMS symptoms change. They'll say, I used to have lots of breast tenderness, but now that doesn't seem to be an issue anymore. My issue now is that I have no libido, and that low libido would be more associated with the depleted dopamine. So there's this huge interplay between the neurotransmitters and the hormones, and they don't occur in isolation, and they don't work in isolation. So yes, you can see this change in pattern.
Another idea that's coming to mind is from a very kind practitioner who showed me her biofeedback machine, and I'm just wondering about if you could use something like that to assess whether somebody is in this hyperactive state. And I guess I should explain this. It was a visual computer-generated image where you had a peaceful scene, and depending on if your sympathetic nervous system was activated, was depending on what would happen in that scene that was projected on the computer. It was very weird. I remember being so skeptical at the beginning, and then I changed it, and I was like, this is really quite strange. It was really fun to do. And I thought, what a great way to initiate this feedback where the patient can really, not just control, but measure how they're affecting change in their nervous system.
I think I saw it many, many years ago when they were measuring beta waves and alpha waves and things like that from the brain. And so I didn't see it with the pictures, but that's really, really cool if they sort of like change the program to do that. And absolutely, because the dopaminergic system becomes overactivated when the body is more in a sympathetic state. So, the reason why it becomes overactivated is because you're losing a lot of those inhibitory neurotransmitters like GABA and serotonin because of depletion along the line or for various other reasons. So if you can control your parasympathetic, sympathetic nervous system and control your stress level, so to speak, you can absolutely start to affect these neurotransmitters and hormones. And that's through, behavioral therapy. Ultimately, I think that is an amazingly good tool, and probably more of a permanent kind of resolution to fix a lot of these issues, because you're changing behavior or you're teaching yourself to behave differently in certain situations. Because I think that's one of the big things we have is stressful society, and you get into these patterns and you just can't get out of a pattern. And so we become essentially addicted to stress in a large way.
Yes.
So we have this constant dopamine high. So even, you executive who comes back from work, he can't sit and relax because he needs that dopamine rush. So he'll have alcohol or something like that. So he's always trying to keep that overexcitation happening. Which works for a certain period of time, but then everything else gets depleted. So if you can modulate behavior like that, that's a very, very powerful tool.
Now, that's an interesting thing you said, addicted to stress. I think our 21st century lifestyle, it's like, welcome to it. But, okay, so let's talk about being addicted to stress, that, I function under pressure, quote, which obviously is deleterious when it's chronic. We're going to run ourselves into the ground. That's what we call overstressed. How, therefore, when one is in that pit, when one is right there at the point of the craving, and whether this be food, alcohol, illicit drugs, sugar, whatever that be, how can you change, or how can you make patients aware that it's happening right now and you need to activate something, rather than just going, oh, I'll just do it again
I guess from a monitoring perspective, because people, when they are in this state, they don't realize that's the way that they are behaving. You don't recognize these patterns when you're in that state. You just want the fix. So I guess if you wanted to monitor it, and there's I'm not very savvy on these things, but you can get heart rate variability monitors. There's so many apps and gadgets and things out there.
Right.
Some of them really, really easy, like clips on the ear or clips on the finger that can monitor sympathetic and parasympathetic response.
Yes.
And I've had quite a few clients who use that, and that it has changed their behavior because they are, stress addicts. They are, they never sleep. They just work, and they train. And then when they start using these devices, it's like, the thing, let's say, beeps or whatever, but it alerts you when you need rest. And they start to like, oh, okay, I need to slow down. And I have found that remarkably, a lot of them have just calmed down so much, they've changed their behavior because they get alerted to it in real time. So, that way it's not like you have to go to the practitioner to get, let's say, a test done. It's just a manner of monitoring yourself during the day and then getting these alerts when you are going into that state. That would be a good way to sort of monitor it. But then there's also, if you wanted to sort of treat it from a biochemical perspective, there's a lot of nutrients and herbs and things you can use as well to help and modulate this dopaminergic function and correct things over time too.
Just before we move on to nutrients and herbs, which I think obviously is what we need in practice, but you said something there regarding a clip for the ear, and I've spoken to Emrys Goldsworthy about vagal nerve stimulation with the forgive me if I get this wrong, Emrys, it's a clip that goes on the internal concha of the ear. So it's not just a treatment, but a monitor.
Yeah, as far as I'm aware, there's a monitor.
That's cool.
It takes data. It draws you little graphs. You can sort of track. You can exactly see when your stressful periods are and when you're relaxed. So you can track your sleeping patterns, your exercise patterns. And this is, people who love data collection, they'll love this kind of stuff because they can really, even if food, for instance, there's a lot of food that can trigger an adrenaline response as well. Food allergies or food intolerances will trigger this excitation response. So you can even sometimes times it to meals and then say, well, what am I eating in that meal that is driving my sympathetic nervous system? So there's a lot of really cool information that you can get from these kinds of devices.
So with regards to nutrients and herbs, and I've got a couple of ones that are just dear to my heart. The first one is if you like, the poster child of relaxation, the mineral, and that would be magnesium. And the herb, of course, for anxiety would be kava. How often do you use these, and do you check the patient and align the choice of therapy with the patient, or do you tend to sort of say, yep, these work for most patients, so I use them all the time?
I have my favorites. I'll be honest. I think we all have those traps where we have our favorite things that we always go to first. I certainly do, kava, magnesium, great, because especially kava works on the GABAergic system, which quietens down that dopamine, that stress response. I like to use GABA quite a bit, which could work similarly to kava. There's other herbs. If you want to tone more on the dopaminergic system, you can use herbs like rhodiola, which is a very prominent dopamine herb because it enhances the release of dopamine in the synapse that can then combine with a post-dopamine D2 receptor. And to a large degree, it also inhibits the MAOA enzyme activity, which then can allow for more residual dopamine to be transferred to the vesicles of presynaptic neurons for higher dopamine release. So that can sometimes quieten down a lot of cravings. So, it gives them that dopamine fix, and then they don't need to do anything else to get their dopamine levels up. So that's really another nice herb to use. And then, you've got your N-acetylcysteine, which is another one that can also drive the glutaminergic system to release dopamine at the nucleus accumbens, which is where the reward side of the brain is situated. So I'll adapt therapies depending on some of the other symptom pictures as well. So I can find things that will sort of cover a wide range of things.
Yeah.
So there's quite a few amino acids and herbs that you can play around with when it comes to the dopaminergic system.
Now, I've read a lot, there's a bit of controversy whether GABA actually crosses the blood-brain barrier when you give it orally. However, there's other work that shows that, okay, that might be the case, but let's talk about the gut-brain axis. How do you think it's working?
Yeah, no, I agree. Like from my research, it won't cross the blood-brain barrier in its intact state unless the blood-brain barrier has been damaged or compromised in some way.
Of course, yeah.
So sometimes if someone gets a really good result from oral GABA, it could be another maybe telltale sign that they may have a compromised blood-brain barrier. But you are correct. Like I think a lot of the GABAergic activity can come from the gut itself because there are GABA receptors in the gut. So that may be why a lot of these powders and capsules work. You can use other forms of GABA that are supposedly crossing the blood-brain barrier as well. I don't think they're really available here in Australia, but there's your phenotropic GABA, I think, is one that crosses the blood-brain barrier. But, you don't always have to get things into the brain. It's exactly like you said, there's this connection between the brain and the gut. So you can work on GABA from a gut perspective, but you can also work on it from a hormonal perspective because there's a huge relationship between progesterone and GABA as well. So, you lift the progesterone up in those who are low in progesterone, and that could also have a GABAergic effect. So that's why you have to look at the whole person and decide, well, should I be treating this from a hormonal perspective or a gut perspective? Or, whichever perspective. And they'll have flow-on effects towards each other anyway and benefit other areas too.
What about things like, for instance, pregabalin, gabapentin, fraught with side effects? Not just that, but also titration issues. You've got to find the personalised dose. With regards to oral GABA, do you find that you've really got to play around with the dose that suits the patient, or do you have a standard dose that tends to work for most people?
The types of GABA, I usually find that most people will respond to, maybe 200 milligrams of GABA if we're talking about the capsules. There are those occasions, especially when people have been addicted to benzodiazepines or are using benzodiazepines. Those receptors are so desensitized that you will need really large amounts of GABA in those people to work. So, you sometimes have to adjust the dose, but it's always good to start low and then just work your way up and see how they go with it. When you use, more absorbable forms like liposomal forms, then you can get away with a lot less.
Yeah.
So it'll depend on the delivery mechanism on, I guess, how much you would want to use, but I don't necessarily believe in more is better. It's always about the minimum dose that gives you the maximum benefit.
Yeah.
So that's the way that I like to work.
Yeah, I totally agree with you. I'm glad you say that because I really think it becomes this bang for buck question.
Yeah.
You've really got to think, well, how much am I getting here and how much is it costing the patient?
Absolutely. And like I said, if you just have to give them GABA, or dopamine all the time, then you need to look at it from a different perspective. You need to think, well, maybe the receptors are not working. So am I doing a service to this person just pushing more substrate in and it's not actually binding to the receptors? It's the same as insulin resistance. If someone is insulin resistant, do you just want to give them more insulin or do you want to fix the insulin resistance? It's the same with dopamine and all of these other neurotransmitters. You want to fix the resistance if they are not responding appropriately. So it's not always about just driving more serotonin, dopamine, or GABA into the body.
I've long had a concern with bioidentical progesterone in that it is a Band-Aid. It's okay to use a Band-Aid if you've got a cut that's bleeding. It's a short-term fix, but it's not going to really stop the issue. What do you advocate with regards to the hormonal treatment of, dopaminergic or addiction issues?
Well, the short term would be to work on the neurotransmitters themselves. So whether I'm using rhodiola or GABA or what have you, is trying to get that neurological effect quickly in so they can start to feel a little bit better. But you are absolutely right. This should still not just be the focus because a lot of this is driven by inflammation. You get increased cytokines and chemokines. It creates this inflammation in the brain, which then overactivates this dopamine system. And you've got to be really careful with things like progesterone as well, Andrew, because if you give someone progesterone that has a lot of inflammation, oxidative stress, and gut dysbiosis going on, then progesterone can actually become pro-inflammatory. So it's not always, a great way to go, even if they may need it. So I would start looking for where's the inflammatory source coming from. Do they have gut dysbiosis? And I mean, so many people have gut dysbiosis. Do they maybe have viral infections or other infections or toxin overload? Or are they overtraining that may also be creating, too much stress? Or is a diet bad, because even inflammation can come from a bad diet, too much sugars. And that's where it becomes tricky, because a lot of that is driven by the addictive behavior. So sometimes it's about making dietary changes. Sometimes it's about treating gut dysbiosis or infections. I would really treat the root cause separately, depending on what is it for that person. Yeah. But that is exactly what you should be doing, is looking for the root cause. Just trying to patch it up with neurotransmitters and hormones is also not the long-term solution.
Of course, you mentioned the granddaddy of treatment paradigms, I think, and that's inflammation. And it just comes up time and time again. As an intervention, do you tend to use these relaxing herbs, magnesium, maybe a little bit of zinc to look at the underlying, let's say, a more gentle, conceptual sort of way of reducing inflammation? Or do you tend to use anti-inflammatories like curcumin is the poster child, but you've also got other things like boswellia and things like that?
I do use turmeric, probably not as much as other practitioners. I guess I like to use the minerals as well, such as magnesium and things like that, to sort of quieten down those NMDA receptors. So I like to sort of focus on the brain inflammation from that perspective. But probably one of the, I would absolutely look at the dietary aspect. And I know that diet can sometimes be really hard for people, but just putting them on a Mediterranean style diet and start reducing those sugars and starting reducing that inflammation. Because I find even by doing things like turmeric, it has very limited effect if there's still something majorly in their lifestyle that is driving that inflammation. So I may do like bits of everything. I'll add in some minerals. I'll add in things like the turmeric or boswellia, herbs like that, and then absolutely make sure that there isn't anything in their diet that may be really affecting them. And I'm not necessarily saying an extreme diet, but if there's something that really just stands out as like, this is really not good, then we need to work on that. And let's say it's alcohol. Let's say they're drinking alcohol and that's causing a lot of inflammation. Then I may sort of say, well, let's do the GABA to try and reduce those alcohol cravings so that we are not producing all of this inflammation. So it's just working it backwards and seeing what is the biggest trigger of their inflammation and seeing how best we can remedy that until we can dig deeper and deeper and get other things fixed along the way as well.
What about co-treating within the medical paradigm?
Well, yeah. I mean, you would absolutely never want to take anyone off any medications that was prescribed to them. And there's a lot of different ways that the medical paradigm works, as flawed as it is, in my opinion. There's a lot of drugs that can be used, and we can use a lot of our nutraceuticals along with these treatments without any effects. I mean, if you look at what is the triggers for relapse, it's things like stress and depression, anger, anxiety, and cravings. And we can work on all of those levels from a nutritional perspective. Now, you can use chromium for cravings. You can use things like GABA or kava for anxiety. You can work very well along these lines of addiction drugs or drugs used in addiction without compromising the effectiveness of the drugs, but maybe reducing the relapse or the risk of relapse when they are on these drugs. I mean, the problem with the drugs, a lot of the drugs like the benzodiazepines that's used in alcohol addiction, is that they can become addictive themselves. So there's which is why it's not, in my opinion, a very good long-term solution, apart from the fact that the relapse rates are so high. So I think using nutraceuticals in conjunction is a fantastic way to reduce that risk of relapse, so that they can eventually come off the drugs and then maybe continue with some of the treatment strategies and keep themselves free of these addictions for hopefully as long as they live.
Where can practitioners find out more? What, in your opinion, are the best sort of resources to go to?
Well, there's I really love the research that's done by Dr. Kenneth Blum. So he's done some remarkable research, and like I said, they're still in the process of doing research, and they've got this substance, he developed a substance called KB2020, which is also known as Synaptogen X or Synaptomine, that they are trialing in a lot of rehab clinics. And when I was looking at the results that they were getting with it in terms of cocaine addiction, heroin addiction, alcohol addiction, and how much it reduced relapse, it was just phenomenal. It was,
wow.
You almost looked at it and you thought, this cannot be true, that something can be this effective.
Yeah.
And these are all done through nutritional, interventions. So if you Google, I don't have a website, but if you Google him and his work, there's a lot of research papers on that, fascinating research on the whole dopaminergic system. So that's probably one of the big sources that I would go to for information.
Brilliant. So we'll put that up on the FX Medicine website for our listeners. So go to there, fxmedicine.com.au, log in if you need to, and you can find out more about all of the podcasts, but certainly about this one. Elizma, thank you so much for taking us through that. That was really enlightening. I actually really admire the way that you say, I'm not a specialist, I'm a generalist, and there's a reason for it, But I do like the way that you connect the dots. You dive deeper into symptomatology and don't just, think about attacking something on a surface level, but looking at the real reasons for the causation of it. Thank you very much.
Well, thank you, Andrew.
This is FX Medicine. I'm Andrew Whitfield Cook. Don't forget to visit fxmedicine.com.au for today's show notes, extra research and other resources.